not looking, don't seem to have got old at all. And it's very nice to see all my Bangladeshi colleagues from Ethiopia, Nigeria, and Pakistan. So thank you very much for joining. And today our webinar is about uh, something which is actually a game changer as far as newborn care is concerned, and in which WHO has done phenomenal work in the recent past. And that is about kangaroo mother care. And we'll be just jumping into it. I hope to keep the presentation quite short. And I have asked Flavia and Marianne to give me a reminder once it's around, 20, 25 minutes up, because this is a topic which is I'm so passionate about that I could go on and on. So therefore, I would really appreciate if Flavia or Marianne can give me, a timer kind of thing at the end of 25 minutes so that we have lots of time for discussion. Um, I also know that as far as kangaroo mother care is concerned, some of the sites have been doing extremely well and also adopted immediate KMC, and some of the sites are still struggling to ensure that they do KMC for some hours. And I must say that in the first phase of ACS IR implementation research, we have focused on KMC, but not so much on the duration of KMC, but we will be talking a lot more about that. So my topic today will be on something which all of you all know. Whatever I'm going to say today, I don't think there's anything new, whether it's problems of low birth weight or the benefits of KMC. What are the current recommendations and implementation guidelines? And also would like to share with you all new research and resources which WHO has developed over the last few years. So we come to the standard slide that we have, which was part of our IKMC implementation, after the trial, the dissemination deck, where we know that low birth weight babies and preterm babies, though they constitute only around 15% of all births, they account for 70 to 80% of all neonatal deaths. And the sad part is 95% of them are in LMICs. It's not only about survival, but these babies are also at risk for growth retardation and developmental delay. So both survive and thrive components are affected for these babies. And our goal, you and I, are all working towards improving this. Yes, antenatal corticosteroids is one big intervention that we are focusing on. But the other big change is kangaroo mother care. If we look at the problems of low birth weight, we have so many of them. In fact, when we counsel families on day one of admission for these preterm babies, especially less than 32 weeks, we sort of hesitate to account all the problems because it can be mind-boggling for the parents. But we as neonatologists do know that this small baby, the smaller they are, the more problems that they can get. And whether it's hypothermia, hypoglycemia, apnea, infection, and of course, the worst, even survival can be a question. And we have one intervention in our arm, which is kangaroo mother care, which has been a game changer. Now, kangaroo mother care has not it's not new at all. It's been there for more than 50 years. But the research on kangaroo mother care and the new recommendations have all now told us that the benefits of kangaroo mother care is huge. We know the components of kangaroo mother care, and while there are mainly three components, the one which we are focusing on, particularly in the facility, are the first two. That is continuous and early and prolonged skin to skin contact, what we call as a kangaroo position, and exclusive breast milk feeding for these babies. It could be by a cup feeding or by direct feeding, but the idea is to give only mother's own milk. And of course, a third component where we have early discharge and adequate follow-up. In LMICs, early discharge is a norm. So KMC may not make it earlier, but it's important that we keep these babies on good follow-up. As part of ACSIR interventions, our main focus is in the facility, and therefore we are going to be focusing on the kangaroo position and kangaroo nutrition or exclusive breastfeeding. So when we look at the benefits of kangaroo mother care, in fact, every problem that a baby can have Kangaroo Mother Care has some benefit for it. It started off as a best incubator to provide warmth, provide physiological stability. But now we know that the benefits of KMC is much more than that. Even for a baby with respiratory distress, when we put the baby in KMC, it improves oxygenation, it reduces apnea, and it reduces hypoglycemia, infection. It's a very, very important part of developmentally supportive care, as it is one of the interventions to reduce pain for the baby. It promotes sleep, and it has long-term effects, whether it is growth or neurodevelopment. And when we look at the best form of evidence, Cochrane review has shown that newborn mortality could be reduced by 40%, a huge 40% by just doing KMC. So probably we could even reach the ENAP targets by only this intervention. One of the big concerns about Kangaroo Mother Care and having the mother in the unit has been about sepsis, but KMC is also an infection prevention tool. It reduces sepsis by 65%. It reduces hypothermia, as we all know. But one of the biggest benefits is on preventing hypoglycemia, improving breastfeeding and improving growth, and reducing readmissions. This is all what we know. But it also has benefits to the family and particularly to the mother. It improves her confidence, it improves successful breastfeeding, it decreases her depression, improves bonding, and to the family, the babies go home early, they are healthier babies, they don't have to spend much money on the baby because there's earlier discharge, and they have a baby who is much better physically as well as mentally. And we also know that it's the best form of developmentally supportive care. If we look at DSC, and I know we will have one more webinar on DSC, but the senses when we look at tactile, vestibular, gustatory, olfactory, auditory, visual, the preterm babies need the optimal mix of stimulating these senses. And among them, the one that we need to stimulate the most is the tactile vestibular sense. And thereby, Kangaroo Mother Care becomes the best form of developmentally supportive care. It protects from pain. So please don't hesitate to do a venipuncture or a heel pricks when a baby is in KMC position. It's better. And if you tell the mother that her presence will make it better for the baby, the mothers will be strong. The mothers will be able to do it. Even breast milk, by just putting breast milk into the baby's mouth, also decreases pain. And please note that KMC promotes normal sleep. And sleep is very important for the newborn. Sleep is a time when the synapses are connecting, when the baby is growing, and therefore having good sleep is important, and Kangaroo Mother Care promotes it. So the babies sleep when they sleep, and when they are awake, they are more alert. And please also note that mothers also fall asleep. Anyone who does KMC, the oxytocin surge will help them feel more calm and they can go to sleep. So when you're doing continuous prolonged KMC, please ensure there's a binder because this is a very common scenario and baby's safety should not be compromised. Exclusive breastfeeding is a second component of Kangaroo Mother Care, and we do promote the smallest babies to be put to the breast. It's not about nutritive sucking. We just want the baby to do something at the breast, be it massaging the breast with their hands, like you see this baby here. It could be just the baby licking. And if the baby can drink milk, very good. So even a 28-weeker should have an opportunity to suckle at the mother's breast. And exclusive breast milk feeding should be the norm for these babies. Because we know that preterm breast milk is much, much more than food. It's not only about nutrition, even nutritionally wise, we know that the protein content, which is so important for a preterm baby to grow quickly and double the weight by, just 2 months, the protein content is double in preterm breast milk, but it has all other components which protects the baby, like human milk oligosaccharides, IgA, lactoferrin in much larger amounts than even in term milk. And this providing human milk to the baby, the mother's own milk, helps in establishing the right kind of microbiome. And we also know that having the right kind of microbiome is so important for the brain development also. So the focus is on mother's own milk. And again, we'll have another webinar on human milk and breast milk feeding. But in the context of KMC, KMC is a very, very important intervention to help the mother to express more milk. In fact, if you have a mother, even a term mother, who is not able to lactate well, putting the baby in skin to skin contact for just half an hour would help the mother to lactate better. And KMC makes better parents. There is enough evidence that KMC reduces postpartum depression and maternal stress, and the mother becomes a better mother by providing a better stimulating environment for the baby. So, this is all physiology, what it could do. But do we have evidence that it improves neurodevelopment? Yes, we do. So, in the context of ACSIR, kangaroo mother care is an important intervention to reduce mortality. But KMC is much more than that. It improves neurodevelopment, and we have evidence which has shown that even at 1 year, comparing babies who have even exclusively breastfed, KMC improves the neurodevelopment and the neurodevelopment scores for the baby. Even in our own unit, where we practice KMC as a routine, even for sick babies, for the past decade, we have been putting babies who are sick on the ventilator in KMC. And we start KMC even as early as the first day and try to provide prolonged KMC for more than 8 hours. And when we compared the group whom we have been successful in doing that and the babies who were not started early, we found that the BSID scores were much, much better at 1 year. And it doesn't stop there. We have been doing studies at, say, at 1 year, but in Bogota, which was the original place where KMC was born, the original RCT babies were followed up for 20 years. And it is so surprising to know that even after 20 years, the brain of a baby who has received KMC is very different from the brain of a baby who has not received KMC, a preterm baby. In fact, the brain of a preterm baby who received KMC is like any other term infant. And these babies at 20 years had lower neuromotor disability, better school attendance, and even they were earning better. So it's not about a few hours, a few days, a few months that the benefits are for. It is lifelong benefits that we are providing to the baby. And therefore, the question is, KMC is about survival, KMC is about brain power, and the same concept of zero separation that we do for a term baby should be applied to even a preterm baby, because a preterm baby is more likely to need it. So how can we do it is a question. So till 2022, till this trial which was conducted by WHO showed its results, kangaroo mother care was recommended for only stable preterm babies. So you wait for the baby to come off respiratory support and then you start KMC. But the problem with this is that many babies would succumb in the first 3 days, and the duration that we were starting was much later. And therefore, the question arose, can we start KMC even before the baby is stable? Is it safe? Will it make an impact on mortality? And this was a multi-center, 5-country trial, randomized control trial, 4 countries in Africa, Nigeria, Ghana, Malawi, and Tanzania, and in India. And this had a sample size of around 6,000 babies, where it was 2-arm trial. In one arm, you started KMC once the baby was stable, but mind you, they gave good quality KMC. Even in the control arm, the duration of KMC was around 19-20 hours by the time they went home. Whereas in the intervention arm, we started KMC as soon as the baby was born. And even if the baby was sick, like you see here on respiratory support, the baby was provided the support in skin to skin contact. So this was the main intervention where we try to give KMC for prolonged duration, aiming at more than 20 hours, provide breastfeeding, and you try to do all procedures for these babies in skin to skin contact. And for this, if you want the baby to be with the mother for 24 hours, we need to provide a good environment for the mother. And please remember, these are mothers who've just delivered. And usually the mother who delivers a preterm is herself sick. So we need to ensure that she is safe and we give her a bed where she can lie down and provide KMC for prolonged duration. And that is where the mother newborn ICU was set up. And in India and Tanzania, a whole new ward was set up. But please don't think that that's the only way to go. I need a new ward. Even in existing NICUs, like in Malawi, Ghana, and Nigeria, they remodeled it to accommodate adult beds so that they could provide prolonged IKMC. Having said that, In this study, they provided for a duration of around 17 hours per day of KMC even during an ICU stay. If you do not have an MNICU, it is still possible to do at least 8 to 12 hours of KMC with just a reclining chair, and MNICU is not absolutely essential for you to do prolonged KMC of more than 8 hours even for a sick baby. So what we found as the outcome of the study was quite mind-boggling. This was a study which the DSMB, the Data Safety Monitoring Board, told us stop at midway because it was already showing benefit. When we stopped the trial halfway, 25% additional reduction in mortality was shown, and that is why the DSMB said it's no longer ethical to continue with the study. And as expected, there was a reduction in hypothermia. Nothing surprising, right, when you keep in skin to skin contact. But what was really surprising, even to investigators, was that sepsis, which all neonatologists were worried about, because now you are allowing the mother and an additional surrogate to enter into the NICU as be in our sterile NICU for a prolonged period, even sepsis was significantly lower. So KMC is definitely an infection prevention tool. But for this to happen, we need to have a policy change. I know there are centers which do not allow mothers to come into their NICUs 24/7. Mothers are usually visitors, or sometimes the babies are handed over to them outside where they breastfeed and give the baby back. It is very important to change this policy and not only allow mothers, not only welcome mothers, but go all out there and get mothers into the NICU and try to establish an MNICU, because this has really revolutionized the way neonatal intensive care is provided. We definitely need to make sure that these small babies are safe. It's not about just giving the baby to the mother. We still need to provide CPAP. We still need to monitor the baby. We still need to give IV fluids to the baby because these babies are small and sick. At the same time, we need the comfort of the mother. So we need a pantry, a washing area. We need an area where mother can be examined, and obstetric rounds need to happen within the NICU. I know many of the neonatologists will be worried when there's so much of a crowd coming in, but please, in an MNICU, these things are possible, and we need to ensure that the mother's care is also good. So an MNICU is an area where there's obstetric, neonatal, and nursing collaboration to ensure that the best outcomes happens to the baby and the mother. So this was a landmark IKMC trial. But at the same time, WHO also did two other big trials in the last 5 years called as the Scale Up KMC, which was a trial, which was an implementation research like our ACSIR. In fact, it was probably the first implementation research that the newborn unit in WHO took up. And here it was done in Ethiopia. I know Abby's group was part of it. And in India, and there they gave us a goal to say you have to achieve 80% coverage in your sites. You do whatever you want. And it's not about one baby, two babies, two facilities. It is in an entire population like a district. And surprisingly, even to us, we managed to do that in a short duration of 2 years. We could get effective KMC by doing a lot of interventions, and it was possible to scale up KMC. And all the results of these studies have been filtered and has come out as an implementation strategy on how to scale up KMC. The other big trial that WHO supported was a community KMC study, where it was shown that if babies have not been started on KMC in the facility, either when they come home or if it's a home birth, we can start KMC for these babies with the help of community health workers, and that could make a big difference to these babies. So the learnings from these three big trials have shown that by IKMC, you can save around another 150,000 lives. By Scale Up KMC, if you provided it for all babies and achieved 80% coverage, another 150,000 lives could be saved. And with Community KMC, you can share a whopping 250,000 lives. So this definitely is a game changer, and it's very, very important that each of us here who are working with newborns take up Kangaroo Mother Care as something that could revolutionize the outcomes for these babies. And that has been emphasized in the past in all WHO documents. And in the recent 3 years, we have come out with so many documents focusing mainly on Kangaroo Mother Care. And I would request the mentors to get familiarized themselves with these documents, whether it is the WHO recommendations, which now states that you should give kangaroo mother care immediately after birth and at least for 8 hours per day. And we have the global position paper on KMC, the implementation strategy on how to scale up KMC, which is mainly the results of the scale up KMC study. And very recently, just in the last 4 months, we have a kangaroo mother care practice guide which has come out, which gives you detailed step-by-step things on how to do. And we also have a counseling guide. So there are a lot of resources from WHO which you could change to your own language and you could use to ensure that KMC does well. I know there are concerns about culture, maybe in our country it doesn't work well. All these barriers which we have to overcome across all countries, across all religions. Kangaroo mother care has been shown to be possible and effective. So, and therefore now, as part of the ENAP indicators, there are some new indicators which has been suggested, and kangaroo mother care is one more indicator which all countries have to now report on as part of the ENAP indicators. So now let's now come to the nitty-gritty of how to do kangaroo mother care. And now we know that it's not only for babies less than 2,000 grams, it is also for all low birth weight babies less than 2,500 grams. And we have a lot of these babies in our postnatal ward, 2 to 2.5 kgs. We need to ensure that KMC is provided to them too. We definitely need to provide KMC for all stable babies, but we also need to provide KMC for the sick babies who are on respiratory support, IV fluids, and oxygen. And this KMC position is something that we need to help the mother with. A well flexed position, but ensuring that the head is turned to one side and the airway is open so that the babies can breathe very well. And here you have pictures from the KMC counseling guide, which will help our nurses explain to the mothers on the KMC position. The binder becomes very important when you're giving prolonged KMC because, as I said, the mother relaxes. She may not be able to monitor the baby all the time. And keeping the baby, particularly when it's a sick baby who is on CPAP, like you see here, keeping the baby well bound is very, very important so that the neck is open and the breathing of the baby is good. These tubings can be pinned onto the shoulder of the mother and she can continue to provide care. Who gives KMC? Obviously, it is the mother. In fact, in every international KMC conference, there's usually a debate, should it be KMC? Because we say that the father can also give, the grandmother could also give, or should we convert it into kangaroo father care, kangaroo family care? And this is a debate which always ends with the same decision that yes, family can support, but the mother is the key. Because let's remember that skin to skin contact you can give. But a lot of benefits are through breast milk, and that can be provided only with the mother. So even when we are giving prolonged KMC, please ensure that the mother can give at least around 8 hours, and the rest of it, the grandmother and the fathers and the other family members can support. Twins, before I remember in my early days, we used to separate twins. But now we know that even twins, triplets can all go onto the mother's chest. Feeding should be encouraged in KMC position. You don't have to lift the babies out. She can express milk in the KMC position. She can cup feed the baby. She can tube feed the baby. The mother is a very, very important monitor. And even in KMC position, both the health personnel and the mother should monitor the baby, not only for temperature, but also for airway, breathing. So if you have a sick baby, it makes sense to have a continuous pulse oximeter on this baby. If you have a dearth of pulse ox, you could do intermittent monitoring, but we need to monitor the breathing and the saturation. Breastfeeding and support is needed. Compliance with kangaroo care, usually we have a sheet which I'll be showing, and all mothers should be educated on recognizing danger signs. Please remember when you do IKMC and put sick babies on KMC, there are times when a baby can become apneic. There are times when we have to resuscitate the baby, and the mother, therefore, should be aware of all the danger signs. Education and empowerment, her understanding becomes important, and follow up and growth and well-being monitoring is also a very important part of KMC. So, how long do we need to provide KMC? Each session should last at least 1 hour to 90 minutes because if you do it shorter than that, the stress of putting the baby in and out itself is quite much for the baby. It becomes stressful. So give the baby at least 1 hour on the mother's chest. And your goal should be 24 hours per day. In my unit, we recognize the mothers and call them as champions, and we have different criteria for champions. We have an ICU where sick babies sometimes we have not been able to move them, and we give KMC even for ventilated babies. Whereas in our MNICU, we only give KMC for our CPAP babies. So in the NICU, if they are able to manage more than 8 to 10 hours of KMC, we call them a champion. In our MNICU, the bar is raised because the mother is there all the time, and we call them a champion when they reach around 20 hours of KMC. And believe me, it's only when we started an MNICU and a KMC ward, we realized that these kind of numbers of KMC hours was possible. Till then, we had only heard about it from the Scandinavian countries, but now we are able to achieve 20, 22 hours of KMC. And how long do we give? It's the baby to decide. Once a baby reaches around 2.5 kgs, the baby himself or herself wants to wriggle out every time the baby is put in. The baby wants to explore the world, and the baby doesn't want to be in KMC. So we have this kind of KMC case sheet. You could, I know in Bangladesh, it's been part of their KMC, the vital monitoring sheet itself. So you can see how you can incorporate it in your vital monitoring sheet to look at how long the mother is providing kangaroo mother care. So you could provide KMC in the NICU. So here you have a 600-gram baby who is in, HFNC and in KMC. KMC ward and MNICU helps in increasing the duration, but kangaroo mother care should also be continued once they go back into the community and go home. And for all this, counseling and support is very, very important, whether you provide individual counseling or group counseling. And what really works well is peer counseling. So please don't forget to encourage some mothers who are doing good quality KMC or even grandmothers to motivate the others. But the main barrier we have found for KMC is the health worker. We are scared. We are worried. We want to be under control. We want to ensure that the babies we are managing, especially if they are sick, we are able to monitor them very well in a radiant warmer. So it is a conviction of the health workers which becomes important. So training, skill transfer, mentoring, recognition of the health workers as champions becomes important. And I just want to share one of the things that we have been doing. I've been doing an implementation research on improving the IKMC in one of the districts in India. And the key game changer which helped me to achieve a high proportion of KMC hours and achieve IKMC coverage was when the nursing superintendent of that hospital started providing KMC. And she made a rule that every nurse should have experience in providing KMC. And with that, there was such a buy-in, and their KMC coverage really, really went up. And therefore, the conviction of the health workers is very important. And don't think that, some babies we can't. Like, for example, these are twins. They are 600, 700-gram twins who were with us, who were abandoned by the family. And for them, initially we started with the nurses, but nurses are busy. So we sent out an ad saying who can, provide KMC. And we had this young 20 years girl who was, just completed. She was on a holiday after her college, and she would come every day to provide KMC for these babies. So it's just the will which matters. You'll always be able to find the way. So please understand that KMC is the core component of small and sick newborn care, around which everything else moves. And it's a total healthcare strategy. And therefore, we need to identify babies who need, that is every low birth weight preterm baby. Even if they are sick, we should start. We should continue KMC, maintain prolonged periods of KMC, and also continue KMC once they go home and maintain it at home. So that concludes my talk, and I would be very happy to take questions. And the key objective of this talk is to convince health personnel that this is something that we have to embrace, like how we have to embrace a baby and provide KMC. We as health personnel should embrace the concept of kangaroo mother care so that we can promote it, because this is such a no cost or low cost intervention where the outcomes are tremendously increased, not only for survival, but throughout life. Thank you very much, and back to you, Flavia.
Thank you so much, Suman. 26 minutes. It's amazing. And such a nice talk and so rich. And we already have some hands on. Um, we still have the IEC for KMC. So would you like us to share now or go through the questions and we share after?
Maybe we can take a few questions now and then because we do have time and then go to the IECs. And then we can
Yes,
follow
sounds
it up
good.
with more questions.
Exactly. So we have Dr. Manan. That's
Yeah,
what's the first
thank you
question. So
very
please
much.
go ahead.
Thank you very much, Prabhi and Suman Rao for short but wonderful presentation. And basically, I was thinking not to give KMC who is the supposed to receive the KMC. It's just a crime. It's just a crime not to give KMC who should get the KMC. So I have just wanted to know two issues. One thing is what you have seen shown that the 28 liter and above, so directly put into the mother's breast. Uh, does it make any risk for aspiration? So this is number one. Number two is in terms of prevention of infection. I mean the preparation of mother and the surrogate. What should the precaution? I mean, in bedding, then use of soap like that. So please make comments on these two issues. Thank you, Sumandav, again.
Uh, Thank you, Professor Manan, and very, very, very valid questions. As far as direct feeding is concerned and risk of aspiration, you're very, very correct, sir, that babies less than, particularly 32 weeks, have a risk of aspiration because they don't have the breathing, swallowing, and um, feeding coordination. And therefore, when we say that the baby should be put to breast, in these small babies, ideally it should be on an empty breast. So the mother, after she finishes expressing, that's a good time for her to hold the baby and feed. But we also need to remember when we put very small babies, like we allow 26, 27 weekers also to do, they don't do much. They don't really suckle. So they don't get a lot of milk for them to aspirate. So, and they just lick or they touch the breast, which itself is good for the mother. So we definitely would request to you all to put the baby to the breast and considering the fear of aspiration, putting the baby to an empty breast is what is recommended. Now, coming to the second question about infection, preparation of the mother, yes, we do have recommendations on how the mother or any caregiver should be prepared. So, when we are identifying a surrogate antenatally, so even before a baby is born, when we do antenatal counseling, we talk about kangaroo mother care to them and we tell them, see, very often these babies are born by C-section. We tell the family one person will be busy with the mother because she is sick. Please identify one more person who can give kangaroo mother care immediately to the baby and come into the NICU. And we ask them to be well prepared, having a bath and such things, and wearing a front open gown, which is, totally open. And of course, hand hygiene, nails are clipped, and chains and all. We try to discourage them and we do encourage these kind of hygiene measures before they come for doing KMC. Having said that, in many LMICs, bath is a luxury and these families can be there for a long time. So in such cases, we try to give them a hospital gown to wear so that at least the gowns are clean. And we if only if we feel the mother is or someone is very dirty, we just clean the chest. Otherwise, we don't even clean the chest because even if it is sweaty, even if she has, they are all commensal bacteria. Yeah, they are not the hospital acquired infection kind of bacteria, and therefore we are okay with giving kangaroo mother care even if the mother is not had a bath. But like in C-section, sometimes they don't have a bath on day one. We do still promote kangaroo mother care. If you are still concerned, we ask the nurse to just clean the chest of the mother and then put the baby on kangaroo mother care. Though I personally feel that is also not needed, but I know many of the doctors and nurses are concerned and therefore we say you can just clean the chest and put the baby on the chest. And we try to make attempts, like in these district hospitals where we work, we try to make facilities for the caregivers and others to have a bath, a shower, and then come and provide kangaroo mother care. So I hope that answers your question, Professor Manan.
Yeah, thank you very much.
Uh,
Uh, if I may add something, I think it will be interesting to the discussion. Just to complete, there is a large implementation stepwise cluster RCT that's being done in Europe, where my hospital is part of. We just finished actually, and it's to show that the primary outcome is the reduction of infection in neonates, and we are collecting data on microbiome of these babies, and we're also doing skin swabs. And basically, this comes from IKMC and all these studies that's been presented. But the theory behind it is that the mother, as someone said, the mother flora, it's a commensal bacteria. And actually, it's good for the baby to be colonized with the mother's flora, which is much better than be colonized with the bacterial flora from the hospital, which is pathogenic, basically. So a baby that's colonized with mom's flora, even if the mom doesn't look very clean, it's always better than the pathogenic bacteria from the hospital that grows inside of the incubators and so on. So this actually, it's a part, it's an important part of what's protecting these babies, basically, of not becoming infected with severe infection in the NICU, because they're colonized basically with mom's flora, with community bacteria. So the results will come next year. I think so.
And to just add on to that, there are studies which have shown that babies who have been colonized with multi-drug resistant bacteria, when they have been given KMC, and this was not only in preterm, even in term babies, they have been given KMC as a treatment for a few hours every day. The MDR was less. So this was an RCT which has shown that skin-to-skin contact with the mother can help in overcoming MDR colonization. So there is absolutely no doubt that KMC reduces infection.
So great to have lots of hands now. So there is Dr. Tejani, and then there is one question from the side, and then we have Professor Sanjoy. So we go with Dr. Tejani now. Please go ahead, Dr. Tejani.
Hello.
We can hear you.
Okay. Thank you for the excellent presentation, Dr. Suman. And a few questions. The first question is regarding the KMC. The one component is the feeding. Therefore, with Kangaroo nutrition, the ideal is exclusive breastfeeding, as you have said. But there are scenarios where exclusive breastfeeding to provide is difficult. For example, if the mother is critically ill, or if the maternal death is there, these are some of the challenges we are facing. So what is your recommendation regarding the formula feeding as replacement for exclusive breastfeeding? This is the first one. And the second one is for those babies who are taking KMC at the facility level, additional care such as supplements. So what recommendation regarding the, for example, vitamin D and iron and the likes? What recommendation on that line considering the supplement? And the third question is considering the discharge weight. Yes, one criteria that means is baby has at least continuously gaining weight every day by 15 to 20 gram per kg on daily basis. That could be one criteria. But in some scenarios in our setup, the number of patients is preterm babies eligible for KMC to provide at the facility level, and the number of beds we have is not proportional. We have high flow, and the number of beds are very limited. And in that scenario, what we are looking for is if the baby is stabilized, the vital signs are okay, the feeding is okay, and daily weight gain is okay, even though the actual target weight we are using is 1,500 gram and above, we can discharge. So any recommendation is on this regard, because we are facing sometimes a problem to decide on that line, because currently there is country-wise community-based KMC as well as home-based KMC accordingly that can be provided, but is the actual cut point, the weight that should be discharged from the facility KMC to practice that KMC at the home level. Any comment on that line? Thank you.
Yeah, thanks, Dr. Tejini. 3 questions, and I hope I remember them. The first 2 questions, to some extent, will be also be part of the next webinar, which is on breastfeeding. But to answer shortly, first we should make all our attempts to get breast milk. And I have seen this in the IKMC trial, particularly in places like Malawi. They had these KMC supporters who would go wherever the mother is, even if she was sick, and help them express milk. And it was amazing to see that they come back with such large quantities. You know, when you aspirate, when you take the milk from the mother's breast, even when she's sick, you don't collect them in a cup or so. You just take it in a syringe, and they would come back with around 4 or 5 ml on day 1. So it is possible to get breast milk from the mother, but WHO recommendations are very clear. If there is no mother's milk, the next is donor human milk. And if donor human milk is not there, then it is formula. So yes, if there is nothing else, then formula can be used. But KMC would help in reducing this, especially once the mother is well. Now, the second question, as far as what supplements are needed. Now, less than 32 weeks, yes, these babies need supplements. They would need calcium, phosphorus, they would need multivitamin, they would need definitely vitamin D, and these supplements would be needed for these babies. Again, these will be discussed next time. Coming to your last question about what is the discharge criteria and how do we sort of align ourselves when we have pressure for beds at the same time, the safety of the baby, can we discharge earlier? So this has to be context specific, Dr. Tejini. Um, in fact, 20 years ago, when I did this first trial when I was doing DM, we had no weight criteria. We used to send babies even as low as 1 kg home, because otherwise staying in the hospital in an overcrowded NICU can be worse than going home where they are going to be taken care of. So we have to look at a few things. One is, even if we don't look at the weight, current weight of the baby should be on an increasing weight gain trend. The baby should have no problems, no medical issues. And one thing which is very important, the mother should be empowered. The mother should know what are danger signs, how to care for the baby. So once you assess all this, there are centers which discharge babies very early. I'm not saying 1 kg, but routinely there are centers which discharge at 1.3, 1.4 kg when they are high volume centers. So you have to look at your center and also keep a track on how many of these babies are coming back sick. In my unit, we used to have a policy of 1.4 kg. And now when we added more beds and all to our thing, now we made it as around 1.6. But even now, if we have a bed crunch, we go back to 1.4. So we have a very fluid way of deciding what is our discharge criteria. But empowerment of the mother, the family becomes very, very important. And there is no rule that it has to be a strict weight that the baby achieves before you can discharge them. So for your unit, you will have to decide the policy is considering all these things. So I hope I've answered all of them, Dr. Tejini.
Okay, thank you.
Okay, great. So the question that I had before, Professor Sanjoy, was can low platelet count in preterms interfere with KMC, like 30K or 50K? This is from Dr. Alpana Jahan.
Dr. Alpana Jahan, yes, you can give, but please let us now look at this baby with a little more care that this baby is a sick baby. So the monitoring of this baby has to be much more, and we need to understand why the baby has low platelet count. Maybe it is sepsis, maybe it is, neonatal alloimmune or whatever, but low platelet count is definitely not a contraindication. You can give kangaroo mother care even in these settings. Shall I take the next one also, or is that going to come later?
So now it's Professor Sanjoy.
Okay.
He has the hand up. So go ahead, please, Professor Sanjoy. Good to see you here.
So thank you, Flavia and Suman Rao, for nice presentation. So, Suman, previously we knew that for IKMC, baby having shock and baby under mechanical ventilator was true contraindication. But from today's presentation, we came to know from you that even baby under mechanical ventilator can be given KMC. So my first question is, if a baby get KMC when the baby under mechanical ventilator, do you have any study findings? What are the problems to be encountered or encountered, or the problems arises during giving KMC under mechanical ventilator? This is one question. And question two is that, as you are recommending 24 hours KMC, so do you recommend a new binder? Because the binder we have used previously, probably this type of binder may not function for 24-hour sustainability. So thank you for giving me the chance to
Thanks,
ask
Professor
question.
Sanjay. The first one is about this. The current WHO recommendations 2022 do say that you may not give KMC to a baby who is mechanically ventilated, a baby who is having shock, okay, or a baby who requires continuous monitoring. So when I say that a baby who's on mechanic, the reason why this recommendation came up from WHO is because of the IKMC trial. None of the babies were mechanically ventilated. In Africa, they were not using mechanical ventilator, and in India, they were sending the baby to another ICU to get mechanically ventilated. And since the WHO recommendations has mainly come out from the IKMC trial, it does say that you can avoid KMC for these mechanically ventilated babies and who are having shock. I shared about mechanical ventilation from my experience. We did a feasibility study of 20 babies where we put babies even on mechanical ventilation in KMC and we had no problem. The important thing is these babies should be on continuous monitoring. In fact, I find that as long as you can take care of the endotracheal tube and the tubings and you make sure that they are well attached here and there's no traction on the tube, uh, giving mechanical ventilation is not a problem. The only thing I have not done till now is to give KMC for a baby who is on high frequency oscillatory ventilation. I have not tried that, but I hope to try that sometime. But so mechanical ventilation is not a contraindication as such. It's just that the study and the IKMC study did not involve it, and therefore it is also said as a not a contraindication, but they don't recommend that you start for such babies. Now, coming to babies who are in shock, as long as the baby is, again, in WHO guidelines, do not give KMC. Okay, so it's perfectly okay not to give. In my unit, if the baby is on escalating levels of shock, was just, we have found that the baby's perfusion is poor, we have started inotropes, that's a baby we would actually keep under the radiant warmer and monitor. But once we are on weaning methods, then we try to give some hours of KMC. But again, this is with a 1:1 nurse, this is with continuous monitoring to ensure that there's full safety. And your question on binder is very valid. I'm not sure what kind of binder you're using, but I know in Manikganj, where the IKMC IR was also going on, the binder which has been proposed is like a blouse, and inside you have something to cover the baby, the same thing which is shown in the counseling guide. That is quite conducive, and we usually give at least a couple or three binders to a family so that they can even wash it and use it again and again. The idea with any of the binder is to ensure that the airway is kept open and patent and the baby doesn't slip down. So we need to find a binder which works well for you all, but the IKMC study binder has been used in for prolonged periods for many days also for these sick babies and has worked well.
Okay, thank
Is
you,
that
Suman.
fine? Oh, yeah.
Thank you.
Thanks,
Yes,
Sanjay.
fine. Thank you.
Great. So I would also like to agree with Suman. In my unit, we also put babies ventilated on KMC, including with high frequency, because basically we ventilate more with high frequency with the oscillator more than with conventional ventilation. So most of them, they will be fine on KMC if the parents agree. But it's just the process of putting the baby on KMC that needs a whole security bundle. But it usually goes out really well and they are much more stable on KMC. Now we have a whole round of questions from the site, from the chat. We can go through some of them. And I was thinking that then we can go through the job aid. We can take the question that's there also one hand, and then we can go through the job aid, and then we can take more questions.
Okay, so I'll just take the question by Dr. Shalom Digwu. Shall I answer
yes,
that?
Yes, we can go for that.
So Dr. Shalom Digwu has asked about intravenous lines. You have to be carefully guided as they're fragile and can easily go out. It may also be a hindrance to healthcare workers in the implementation. Totally agree with you, Dr. Shalom. And therefore, when we are placing a baby with lines and all in KMC, especially for babies on CPAP, the transfer itself is a two-person's job. Generally, one health personnel will help a baby put a baby in KMC, but if a baby is sick, the baby is on CPAP, it has to be a two-person's job, one to hold the baby and the other to manage all the lines. And peripheral lines is not so much of an issue. I find it easier when a baby has a peripheral line on the upper limb as compared to the lower limb when we are doing KMC, but it is possible to do for both of them. The important thing is to ensure that you have a dress which is fully open in the front so that you can place the baby and the lines and all can be adjusted rather than have something where you have to struggle to put the baby like this. So having a fully open which you close on the baby would really work well. So we request the mothers, if nothing else, to wear their partner shirts and come in with buttons so that they can provide KMC. But yes, as health personnel, we have to take care of the lines, particularly central lines, because the central lines are much more thinner and they can break and all. We need to take care of it. Yeah. Over to you, Flavia.
Yeah, so we have two more. Dr. Shambal is asking if there is any contraindication to start KMC.
Yeah, contraindication for KMCs are there, particularly with reference to the mother. If the mother has a infection which is transmissible to the baby, for example, we have had cases where a mother has had chicken pox and therefore the mother and the baby had to be separated. And in such cases, or if there's any condition which is infective on the chest, we refrain from giving KMC. Similarly, if there is any surrogates who are supporting the KMC, if they have a respiratory infection, we disallow them. If it is a mother who is doing and she has a respiratory infection, we ask her to wear a mask, wash her hands well every time, the same thing that we did in COVID times, and still continue KMC. So there are very few contraindications as such, and it's usually when a mother is sick, but the same thing can be done with any other surrogate who is well during those times. From the baby's point of view, currently, as part of the recommendations, people hesitate when the baby is on mechanical ventilation, but otherwise, as Flavia said, even high frequency oscillation is not really a contraindication to these babies. And
okay, thank you so much. There is one more, yeah. Can kangaroo mother care be safely provided in air-conditioned room? Also during hot weather, the sweating of the KMC provider affect KMC outcomes.
Yeah, so see, all decos are generally air conditioned, but even in an air conditioned room, any NICU, we ask you all to maintain a temperature somewhere around 25 degrees Celsius. So it should not be a problem, and therefore KMC in an air conditioned room is definitely not a problem. If the mother is feeling cold, then we ask her to wear one more layer of a blanket or a shawl or something to keep her warm, and so that the baby is also warm even if it is an air conditioned room. The second thing is about hot weather. I'm not aware of any evidence, but I can tell you from practice that even in hot weather, where KMC has to be done, one is we ask the mother to just sort of clean up this chest whenever she feels the sweat is trickling down. But I've also had families who use a very thin muslin-like cloth, very thin cloth, as between the mother and the baby to sort of absorb the sweat. I am not totally in favor of it because it's not technically skin to skin contact, but that could be an option. And even in hot weather, we do recommend that the mother goes and sits in a cool area within the house so that the sweating and all can be decreased. But as far as an evidence base, I can't recollect any article, and it has not really shown to provide or affect outcomes. But if there is any liquid, just wipe the surface off is my recommendation.
Great. So I think we have just one more hand, and then we can go for the job aid for the IT. It's Dr. Maria Mukta. Please go ahead.
Yes, thank you so much for this brilliant presentation. I practice in Nigeria, in Abuja, and with the space constraints existing in our institutions, when you want to consider setting up an MNICU, you know, how did you bypass some of the challenges? For instance, if I have a room where, yes, I can put mother and baby together, but I don't have facilities for the mother to have somewhere to eat or somewhere to relax, you know, those kind of recommendations. How does one bring the two together, you know? We've been trying to start an MNICU, but it's been so challenging because of space constraints. What is the minimum requirement to start such a program? Thank you so much. Thank you.
Thanks, Dr. Maria, for your question, because I think everybody here are battling with space, fighting out for every inch for our babies. And here we are trying to ask for an MNICU, which is almost 3 to 4 times the size which is needed to house. You know, you always feel when you look at an MNICU, here I'm housing, I have an MNICU with 7 beds, just 7 beds, okay? But people look at it and say, oh, maybe we could put in here around 20 babies here. So it's always roughly around a third. But the way that we go about it is in most of our places, we do keep the mothers in the units. We don't send them home once they are well. As long as the baby is there in the hospital, the mothers are also given a bed somewhere. So one of the way of negotiating with the administrators is that there is already space given to the mother. Let us just give that space next to the baby. So those beds can be removed, and that's the way that you can discuss with your obstetric colleagues also, that rather than having a bed there, you please make sure that the bed for the mother would be here, and it's therefore the same space that we are looking at. Now, secondly, about other things, about where we can give a space for her to eat, where she, a pantry where she can get examined. I know these are good to have, but sometimes, when we don't have space, we might have to provide some other area. Now, if a mother is sick in our MNICU, we don't have an area where they can go and eat. We have provided the cardiac tables which can wheel in onto the thing, so the mother sits on the bed and eats. And of course, this is a little, our nurses have to wrap their mind around it because you're not used to such things. But
Mm-hmm.
it is possible to do these things when you have space constraint. And slowly, there's nothing like I need 2 beds minimum or 10 beds minimum. Start with whatever you can. The way that we started with was whenever our unit was a little light, in the existing unit, we started getting a bed in so that our nurses could get used to that idea. And only when our administrators could give us a space, we made sure that we had an MNICU. So we call it gambit, get a mother's bed into your treatment area. So so just start off and don't
Mm-hmm.
worry about how many. And slowly you can add more and more beds.
Thank you so much. Thank you.
Brilliant. So I think we don't have questions pending now. We can go. We are 6 minutes past 7, so we still have some time. So we will go for the job aid, and if you still have some questions, you can also keep writing and can raise your hand, and they will also be treated. So don't hesitate. So basically, the whole of materials, so much she already shared, and I put the links for the WHO resources on KMC on the chat. And You're also going to be receiving them from the research teams in your countries. And we have one more resource. So this one is for the parents. So I will share my screen. Just a second. And it's only for ACSIR. So this is one IAC for Kangaroo Mother Care. And the idea of this IAC is to give to all parents that have a small newborn baby. So all babies that are less than 2.5 kilos and all preterm babies. So all those babies that are born and that are supposed to receive KMC, they can receive this IEC in the facility before the mom goes home, basically. And the nurse or the midwife will go through the mom or through the IEC with the mother or the family and do an initiation basically on KMC. Of course, there is a counseling guide that will help them go through the counseling, but this is to give to them and this will stay with them. Of course, our population is less than 2 kilos or preterm, but we are talking about KMC for small babies. So this can be given for all the small babies. So basically, it's only for the parents or for the families. So we have Kangaroo Mother Care, KMC. It's maybe the first time they will be hearing this name. Of course, this can be adapted to if your country has a special name for KMC. Actually, I would be very interested to know that if you have different names for KMC in your countries, you could maybe write in the chat. I think it would be interesting for us to know. But the name doesn't matter. It's more about the practice. So Kangaroo Mother Care, a loving will to help your baby grow. So we explain that Kangaroo Mother Care gives your baby love, warmth, and strength. It helps your baby grow, breathe better, stay warm, fight infections, bond with you. KMC also improves brain development. KMC helps the mother. KMC keeps the mother happy. KMC keeps the mother happy and stress-free and helps produce more milk. The more skin-to-skin contact, the healthier your baby becomes. So we have preparation for KMC. Wash your hands before touching the baby. Wear a clean front opening shirt or dress. Be ready to sit or lie down for 2 to 3 hours at a time. Get the KMC wrap or binder ready. Dress the baby in a hat, socks, and diaper. Then have the KMC position. We use these images because sometimes it's cultural sensitive, some images. So that's why we are not with opening the binder in these positions. So baby's head is slightly extended. You should be able to kiss the forehead, arms and legs flexed, close to the body. Baby's tummy against your chest, baby's bottom supported. If lying down, keep your head raised with pillows, 35 to 45 degrees. So when this is said to the mom, this should be also shown to the mom because we also don't have the image here. So they should not only hear this or read, they should really understand what we are talking about so they can reproduce that at home. How long to do KMC? So each session is at least, so we are saying at least 2 to 3 hours, so never less than that. But of course, we are recommending to aim for 24 hours a day and provide KMC at least 8 hours a day. Who can do KMC? So mother is the best provider for KMC, but father, grandmothers, or the family members can do KMC. During KMC, watch a baby. So teach the mom or the surrogate how to follow, how to check the baby. Check regularly that your baby is warm, hands and feet feel cold, cover with an extra cloth and continue KMC. If the baby is active when awake, breathing normally, feel gentle breaths on your skin. Baby has a normal skin color, is accepting feeds every 2 to 3 hours, is passing urine 6 to 8 times a day, and gaining weight. When to stop KMC? KMC should continue for as long as the newborn accepts it. Typically, newborns consistently attempt to wiggle out of KMC position when they reach a weight of about 2.5 kilos or corrected gestational age of 38 to 40 weeks. And if the parents need help, so it's important that they know that they can get help. So in the context where they are, ask for help from a healthcare practitioner in the hospital where they are right now, or in the community for community health workers that are there to help them, basically. So this is our first IEC, basically, to share with the parents with counseling and with a first contact, basically, for parents concerning KMC. Is there any question, any comment? I have one hand, but it's Dr. Maria. I don't know if it's the same hand or if it's the old hand. Do you have a question, Dr. Maria, or a comment?
It's an old hand. I'll take it down.
An old hand. That's all right. I'll stop sharing them. So this material is going to be shared with all sites, and it's going to be printed, and you're going to have contact with that when you are going to go to the facilities and give your mentorship sessions. All right. So if we don't have any further questions, someone, would you like to?
Yeah, I just wanted to ask, I know, sorry, I did not get any polls ready for this webinar today, but I just wanted to understand from the participants that how many of you all are practicing KMC for your babies. If you could just sort of maybe raise your hands, your virtual hands, it would give us an idea of how it's going on, and especially if you're able to practice for prolonged periods of time. Yeah. So we have around 94 participants for us to just have a look at, how many of you all are actually doing KMC. Because this is one intervention that we want to do in a much even more intensive way than what we have done in phase 1, where we said, okay, just provide some KMC, but here we want to really make sure that we can do it prolonged KMC as the WHO guidelines are. Yeah. Okay. I know it's easier to take a poll than lift a hand up, especially half the time you can't find your own hand in a virtual environment. Yes. So I see that many of you all are able to do KMC, but the numbers is around 15 here. And I'm sure that we can discuss on how we can do well. And as far as mentors are concerned, this is one thing that you will probably also have to if you're already doing very well, great. But I know there are a lot of tertiary care centers where we have great mentors, where KMC may not be optimal. And therefore, this is an opportunity for you all to also see how you can improve the KMC status in your own units, and then go and do the mentoring at the other facilities and improve it there. Unlike say surfactant, CPAP, or antenatal corticosteroids, in tertiary care centers, sometimes KMC is still not the norm, or even if it is done, I call it cosmetic KMC, where you do just some KMC, but not like 8 hours, 10 hours. And therefore, it's something that I would request the mentors to also see. If you think there's a need for KMC to improve in your own units, you can apply the same principles of quality improvement that we are going to be using in our mentorship program to your units to see how KMC can be improved. So thank you very much. I don't have anything else. I think we can finish on the dot today, Flavia. Or if any other, I know I saw Professor Shahidullah here. I see Gesit here, a big time mentor. So if you all have any comments, please come in. And A-Day is here. Hi, A-Day. So if, no, A-Day is not here, sorry. So if any of you all have any comments, please do unmute yourself and go ahead and share your experience or motivation to this group. I think you can.
Good afternoon, Suman. Good afternoon.
Good afternoon.
Yeah, Rosina from Nigeria. Please,
Hi,
I don't
Rosina.
know that document that Flavia shared. Can it be dropped for us to reproduce so that we can keep giving to our mothers here? I love it. It's so concise and the majority of the information are there. Please, can we have it?
That's a
Thank
job
you.
aid? You're talking about the job aid? The one that Flavia showed just now?
Yes.
Yeah. So these are all going to be interventions which will be with you all to be used as you all wish in the intervention clusters. If you would like to use it at your own units, I think you're more than free to do it, please. You can definitely make use of them, not a problem.
So, Suman, I think the question was how we will share it. Will we share it or not? I think there's a folder that's created. Flavia, maybe you can say something about where all the PIs have access.
Yeah, yes, there is a folder for the mentors with these materials, and all the country research teams, they have access and they will share with you. I can definitely share with you this one, but you will have access to all of the job aids and IECs. Right. So if there is no further, we are 3 minutes past our time, which is our best timing ever. So we will be able to end this meeting today, and we will convene again in 2 weeks for our next seminar. Thank you, Suman, for this amazing presentation. Thank you, everyone, for this participation, these really great questions. And again, this will be available on YouTube, and I'm sharing with you the IEC. Thank you so much.
Thank you so much. Thank you.
Thank you.